Recording in progress.
मिल जाएगा, यही मिल जाएगा, अभी मंगा देता हूँ।
जी गुड जी गुड मॉर्निंग। नहीं जी बताइए ना सर।
Hello, Madan. Madan,
Yes ma'am, just
can
1 minute ma'am.
no, can you
Sir,
mute yourself?
can I call you after 1 hour?
No problem. Madan, you can mute yourself because we are recording it already. Yeah,
Okay.
that's it. So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our Head and Neck ACTRAC academic classes. So for today, our speaker is Dr. Madan Prasad Gupta. Dr. Madan is a senior consultant in Department of Surgical Oncology as head and neck surgeon at Paras Hospital, Ranchi, Jharkhand. Uh, Dr. Madan will be speaking on the topic lip cancer causes and management. So with this, we welcome you, Madan. We can see your slides and you can start the presentation.
Thank you ma'am. And I deeply obliged to you and your team giving this opportunity. So today topic is lip cancer and its management. And I think with due permission, should we keep this interactive?
No, Madan, we usually keep it in a lecture way and later on
Okay.
we have question and answers.
Right. Okay, ma'am. Sure. So without delaying, I'm starting my presentation. So the lip is a very soft, mobile structure and highly specialized structure. And it is located at the anterior boundary of the oral cavity. And it is made up of multiple layers, including skin, muscles, gland, blood vessels, nerve, and mucosa. If you leaf from anterior to posterior, this is skin. Then you find muscle. The most common muscle is orbicularis oris muscle, and followed by submucosa and the mucosa. The sebaceous gland is present in the skin, subcutaneous tissues, while the salivary gland is present in the submucosa. So a little bit about the anatomy of lips. So as I said, lip composed of skin, vermilion muscle and mucosa. So upper lip is associated with nasolabial group and lower lip is associated with mentolabial group. The usual length is 5 to 6 centimeter in long. And as I said, the muscular anatomy is formed by the orbicularis oris muscle, the primary muscle, which acts as sphincter, and the other labial glands and mucosa. So the primary muscle is orbicularis muscles, but along with there is multiple muscles which helps in function of the lip, like levator levi on the both sides, zygomaticus minor and major, risorius muscles, and for the lower lip it is depressor anguli oris and depressor levi inferioris, along with mentalis muscles. So blood supply, this is very, very important. The lip is a highly vascularized structure. The primary blood supply is, as you see, superior labial artery for the upper lip and the inferior labial artery for the lower lip. But the most important is it has multiple collateral supply. As both artery you see, it's the most commonly is arising from the facial artery. But as you see, there is a multiple collateral supply from the, if you see, this is the maxillary artery, and from the maxillary artery, this is the branch of buccal artery. And you see, there is a multiple anastomosis. Along with, there is a, this is infraorbital artery, this is also getting anastomose here. Like upper lip, the lower lip is also it is a multiple collateral vessels from the mental branch of the inferior alveolar artery. This is the maxillary artery, again the branch of the inferior alveolar artery, and as you see there is a multiple collateral branch. So why this is important? Because when we plan for flap reconstruction, even we sacrifice the facial artery, we can reconstruct by this based on vessels. So venous supply, as I said, it is almost similar to the arterial supply, like a superior labial vein and the inferior labial vein, and there is also have a multiple collateral venous anastomosis. And the lymphatic drainage is by the submandibular and the submental node. Nerve supply, this is also important. As we know, the main supply is for the marginal mandibular nerve. But the other important is buccal branch. As you see, this buccal branch, most of the cases, this buccal branch supply this lip. So even if we injure, if we some damage the marginal mandibular nerve, the competency of the lip maintained through this branch. The sensory branch is by the superior labial branch of the infraorbital nerve. As you see, this is the infraorbital nerve. And from the lower lip, it is from the mental nerve. This is the nerve. This is piercing through the mandibular foramen and exiting from the mental foramen and supplying the lip. This is the sensory branch. So if you talk about the etiology and the risk factors, so as I said, the lip is made up of skin, vermilion, and the mucosa. So mostly the skin is the etiology, skin lip for the etiology is UV radiation. The patient who is having a more sun exposure and getting a more UV radiations, they have a skin lip cancers. But while on the mucosal side, the most common is tobacco use. It can be smoking or non-smokers. And if a patient is taking the alcohol, it acts as a synergistic action. Other viral etiologies, human papilloma virus and the HIV and other viral etiology. And of course, poor oral hygiene is one of the risks for the mucosal side of the lip cancers, and other factors like occupational hazards or environmental factors may lead to the lip cancer. So this is the world trends. The number of the oral cancer or lip cancer is increasing day by day. It is the projected incidence in 2045 is 600,000 cancer will be involved. And like in India, also we are getting increasing day by day. It is in 2026, it is 131,000 is reported, while it can increase to 1.47 in 2030. So this is the incident rate and this is the mortality trend. So the cases increase, also the mortality rates increase. So that's why it is important to screen the cancer and to diagnose early and treat early. So diagnosis for lip cancer, it is difficult if it is very superficial and the early lesions, especially if there is a actinic cheilitis previously. So actinic cheilitis is regarded as a pre-malignant disorder for lip cancer. Like in buccal mucosa, we have leukoplakia or erythroplakia, pre-malignant disorder. Like that only, actinic cheilitis also act like a pre-malignant disorder in the for the lip cancer. So it should be differentiated from the early cancers. So to detect early tumors, the lip must be palpated as well as inspected visually. Clinically, lip cancer is slightly verrucous changes is there, edema will be there, non-healing lesions, induration and hyperkeratosis. And it may be hints ki it can be a malignancy. And of course, neck we should palpate. And of course, we should palpate the neck to look for the any neck node. And biopsy is the gold standard, like for any cancer. So this is the AJCC addition staging, and for the oral cancer and the mucosal part of the lip, almost the similar AJCC staging. For T1, it is if there is a less than 2 centimeter or equal to 2 centimeter with depth of invasion equal to 5 or less than 5 mm. T2, if lesion is more than 2 centimeter and less than 10 centimeter, but depth of invasion should be less than or equal to 10 mm. But if depth of invasion is 5 to 10 mm, even if a tumor is less than 2 centimeter, it is a T2 lesion. T3 lesions, if tumor is more than 2 centimeter or less than or equal to 4 centimeter with depth of invasion is 10 mm, or any tumor more than 4 centimeter or depth of invasion is less than or equal to 10 mm. T4A is advanced disease if tumor is more than 10 centimeter with depth of invasion is more than 10 mm, or tumor invades adjacent structures like cortical bones, or the like mandible and maxilla, or involve the nearby skin or sinuses, or but we have to keep in mind that if there is as lip is very near to the lower alveolus, if there is superficial erosion or in the bone or tooth socket, it should not be considered as a T4. T4B is if it is a very advanced local disease, like if it invades the masticator space, pterygoid plates, skull base, or if it encases the internal carotid artery. For nodal classification, N1 is metastasis if ipsilateral lymph nodes 3 centimeter or smaller in greater dimension without ENE. N2 classified in N2A, B, C. N2A is if there is a single ipsilateral node larger than 3 centimeter, but no larger than 6 centimeter in greatest dimension, but ENE negative. N2B is if there is a multiple ipsilateral neck nodes, but none is larger than 6 centimeter. And N2C is if there is a contralateral node is also present, but none larger than 6 centimeter. N3 is further classified N3A and N3B if there is a ipsilateral node more than 6 centimeter without ENE, and N3B any node which have a clinically overt ENE positive. So the principle of management for lip cancer is for early lesions, we have two options, surgery or brachytherapy. For the very early lesion, superficial lesion, especially at commissure, we may consider for brachytherapy for better cosmetic outcome and better functional outcome. And for the moderate lesion and the advanced lesion, surgery is the treatment of choice. And depending on the SPR report, we may consider adjuvant treatment in form of radiotherapy plus minus chemotherapy. So for carcinoma in situ, we do leaf save or resection. And for T1 stage 1 surgery, or as I said, for very early superficial lesion, commissure involvement, we may consider for radiation in form of brachytherapy. And for regarding the neck dissection, it's very controversial topic in the lip CA, especially in the early lesion like in T1 or T2 lesions. So generally, for the skin side of the lip cancer, neck dissection is avoided. But for the mucosal side of the cancer, we extrapolate the data, our TMH data for the tongue and the buccal mucosa, which is published in 2015 by the Dr. A.K. De Cruz, sir. And for the mucosal side of the lip lesions, we perform the selective neck dissection for early lesion in N0 neck. But if even in the skin side of the lesion, if there is a poor prognostic factors in form of if there is a poorly differentiated carcinoma, or if there is a perineural invasion, dysplasia, or any bad prognostic factor, we should consider for neck dissection. And if frozen is available, we should consider frozen also. Like T2, again, surgery is a treatment of choice, and very few selected cases we can go for the brachytherapy. And as I said, if there is a tumor is large and tumor thickness is more than 6 mm, poorly differentiated, perineural invasion and dysplasia, we should consider for neck dissection, because these risk factor is associated with high incidence of positive nodes. For T3, T4, again, the surgery is the treatment of choice, and depending on the post-op HPR, we supplement with adjuvant radiotherapy plus minus chemotherapy if there is a margin positive or if there is a extranodal extension. So for a special scenario, if patient is having prior irradiation, so in prior irradiation recurrence cases, we go for surgery. That patient is not suitable for further radiation. So for prior irradiation cases, we should go for the surgery followed by suprahumoid neck dissection. And if there is a prior surgery, then for the radiation, again we recommend for the surgery and followed by HPR report radiotherapy. And if there is a neck recurrence, we do a therapeutic neck dissection followed by radiotherapy. So as I said, role of neck dissection in lip cancer, it's highly debatable and highly controversial. And this is a published systematic review meta-analysis. And their pooled estimate of occult metastasis has shown very low risk of nodal metastasis in lip cancer. So their conclusion was, uh, even if we don't do the neck dissection in lip cancer for early lesion, T1, T2, or very superficial lesions, we can keep patient in a close observation with a viable option. With there is no difference in overall survival or disease-free survival. But yes, we have to keep patient in the close observation. So where we do the neck dissection in lip cancers. This is the one study they have do a lymph node metastasis prediction model. And in their 326 patients, using the Cox regression analysis, they have concluded that, as I said previously, if there is extensive tumor superficially, but extensive tumor, or there is a tumor depth is more than 6 mm, or like grading, if there is a poorly differentiated carcinoma, they have high risk for lymph node metastasis, or in these cases, we should consider for neck dissection. Again, other paper, role of neck dissection in early stage lower lip cancers. So this study was, the aim was to see in any changes in overall survival if you're doing the elective surgery or if you're not doing the elective surgery. But the problem was this study was a very small cohort group, only 30 patients, and 20 patients had pathologically T1 and 10 patients had pathologically T2. And after after doing this study, they have concluded that even without doing the neck dissection, there was no any difference in overall survival and disease-free survival. So this is the important aspect of the lip management for the reconstruction. So for why this is important, because lip, as I said, it's very specialized structure to give the good cosmetic result and the good functional outcome. So reconstruction of the lips, whenever we plan, our aim is to maintain the oral competence, good mouth opening, and the proper speech and swallowing. So for lower lip defects, for a small lip defects, you used to do excision and primary closure. For like we use classic V excision or lazy V excision, or we can have a rectangular excision along with horizontal resection and closure. So for the 1/3 lower lip defects, as I said, classic V excision is used, as you see, classic V excision, and we then we close primarily. And for the why this modified lazy S, because it provide the actual vermilion cutaneous matching. So lazy S is preferred now on classic V excision. So for defect more than half to less than 2/3, we use Abe Savatini flap because Savatini has discovered this flap in 1838. So in this, as you said, as you see, this is the lip lesion in the lower lip. We excised, and same the width, half width of the width of the defect we take at the donor site, but we take 1 to 2 centimeter larger the length, and we rotate and we suture here at the recipient site. And thereafter, pedicle is divided after 10 to 21 days, and during pedicle we make some changes to avoid the notching at the donor site. So the advantage of this flap is it's repair like whatever we are making it's like that like flap only, and eventually because we are making with the lip, it regain both sensory and motor function. Disadvantage is it required 2 stage, and maybe accidentally by opening of the mouth wide may damage of the flap, and the relative might be there will be a relative microstome. Other is a slender cross leaf flap. It is mainly used for the commissure defect. So if there's a lesion is near or at the commissure, this flap is used. It is the principle is almost similar to the Abe flap. We have to excise first, and the half width taken at the upper lip, along with again the 1 to 2 mm longer than the defect. And again, the defect is the pedicle is divided after the 2 weeks. And mostly commissuroplasty is required, and that should be performed after the 3 months. Paraplangic flap. This flap is described more than 100 years ago. This is mainly used for if there is a large lower lip defect. So in this, we take an nasolabial or malolabial groove incision, skin subcutaneous muscle, but we have to keep cautious that the blood vessels and nerves should not be injured. And then after this is mobilized from the perioral tissue, and we can close the even in the larger defect by this flap. Other is Bernard Barrow flap in place of Karapendric flap. In this, if there is a large lower lip defect, we make a borrow both upper and lower, as you see here. So skin and subcutaneous tissue is getting removed from here, from upper lip in the nasolabial group, and here the malolabial group, and then mobilized and then sutured. Along with, as you see, dotted line is the mucosal lining. So we have to mobilize from the outside and from the inside also. And the most important is nasolabial flap. It is highly vascular flap even if we sacrifice the facial artery, as I mentioned in the blood supply around the lip. So for if there is a suppose there is a half lip is sacrificed, ipsilateral nasolabial flap is sufficient. But if there is a bilateral, if there is a whole lip is involved, bilateral nasolabial flap is used to reconstruct the lower lip. So as you said, this is also called a Gates flap. This is the almost lower, complete lower lip effect. So this is the marking in the nasolabial groove and the malolabial groove. And this dotted line is the inner aspect of the mucosal incision. And after incision, as you see, this flap is rotated on the lower lip. This is rotated here, and this flap is rotated here and completely close the lower lip. So for upper lip defects, as like the lower lip, the smaller lesions, it is closed primarily by Weiss resections or VY plastic resection. And for the half or two-third lip resections, it is used by a slender flap if commissary is involved. If not, then the away flap. And for the more than two-third complete lip resection, Dieffenbach advancement flap, plus minus away flap. So similar like principle for the lower lip, this is the upper lip lesion, and we have resected, and the half width is made here at the lower lip, and the rotated and the suture. The other is modified borrow techniques. In is if there is a midline lip defect is there, we make LR yeah, along with nasolabial groove incision, and we remove the skin and the subcutaneous tissue, and we mobilize the lip, and we close with good outcome. And the final is it's a free flap. So most commonly flap used for the lip is forearm flap. So forearm flap is designed using a template matching the defect. And along with flap, we take a palmaris longus tendon. We harvest palmaris longus tendon and keep harvested till the get anchored with moriolus. And with tendon we get anchored with moriolus at the commissure. I mean, during the initially we slightly overcorrect, so the by the time it even if there is a loosening, it may provide a good hanging and structure and the good flexibility. Then the harvested flap fold over the tendon and replicate the vermilion mucosal intersurface. So the other most commonly now used flap for larger defects or if it is both lower lip and the upper lip is involved. So brachytherapy, as I said, it is used only for very small lesions less than a centimeter, or for lesion involving the commissure. And the advantage is it retain the maximum functional ability. So most commonly used source is 192 iridium. The schedule is twice a day, 4 to 5 days, and the total day dose is prescribed is 45 grays in 8 to 10 fraction. So to support the brachytherapy, there is a Dutch data, and this is the largest data. They have shown that brachytherapy is a good option for a smaller lesions, or for a lesion if there is there is at a commissure, to provide the better cosmesis and the better functional outcome, along with lower toxicity. And also they have in their data shown that the local control rate is very good. It is 97%. So, so again, this is the data is published by Poonam ma'am from the TMH. So the objective was this study was to evaluate the sites and to see the prognostic factors with subsites, stage, and histopathological differentiation. It was a retrospective study, and 294 patients was included in this study from the 2012 to 2022. So most common site was lower lip, followed by commissure, and then the upper lip. So on Kaplan-Meier analysis, they have shown that the poor outcome is mostly associated with lower lip carcinoma, and the worst for the commissure squamous cell carcinoma. So they highlighted that the critical role of tumor subsites and stage in determining the survival outcome in lip squamous cell carcinoma, and we should tailor the treatment study, especially for the high risk subsites like the commissure, for the improve the prognosis. Thank you. If any questions.
Thank you, Dr. Madan, for quite a comprehensive lecture. I think
Thank you.
there is one question that what is the role of sentinel lymph node biopsy?
Yeah, it's a very good question. So, as I said, in lip cancer, the still controversial topic is going on, and sentinel lymph node will be the one of the better option to see the node is positive or not positive. But the problem is the availability. If available, yeah, we should go for sentinel node. But if not available, so as I said, if there is a bad prognostic factors like poorly differentiation, or dysplasia, or tumor depth is more than 6 mm, PNI is positive, we should go for the supraomoid dissection.
Yes, I agree with you, Madan. The only thing, like you rightly said, SNLB may be good option, but again, this SNLB facility may not be available everywhere. Moreover,
Yes,
you have to understand that the procedure of lip, because lip carcinomas are so small most of the
yes,
time. If it is a early,
yes,
and I assume that you are doing SNLB for early cancer only. So the primary
yes,
excision may take half an hour, 20 minutes, and your
yes,
the excision of SNLB with the whole procedure may take several hours. So please
yeah,
take into account that
agree.
part also, because
Yes,
everything is associated with monetary aspects, and there are going to be like other issues also. So shifting
very
the
true.
patient and other issues. So there is not much of data for lip carcinoma, and I think majority of this data is still being developed for tongue cancers. But having said that, if it is available and you want to go ahead with that, you can do that. In our series also, the last paper paper which you showed, the incidence of nodal metastasis was around, so if I say all the stages, it was around 50% were negative. So out of those, I think 260 some patients, we had 112 were negative. So no nodes. But rest of the patient had nodes ranging from N1 to N plus. So I would say that even though we think the nodal metastasis rate in lip cancers is less, but it is not like negligent also. So please be a bit more careful when you're treating the neck, because neck dissection will take another 30-40 minutes or 1 hour at max, and sort of you give the full treatment to the patient. Dr. Madan, what kind of flaps you use in your practice most commonly? Because like we saw, you beautifully elaborated all kinds of flaps ranging from local to the free flap. Like what in your practice and to our students also, what do you tell with your experience?
Ma'am, mostly I do a local or pedicle flap for lip cancer. For free flap, only for very large defect, or if it is involving the both lower and upper lips. So mostly I use pedicle flap, ma'am. Local or pedicle flap.
Right. So I think, yeah. So I agree with you. Even we also, most of the time, I think we are able to manage it with some sort of local flap. Whether it is like pedicled, the random pattern nasolabial flap, or we are able to do the different kind of carapenzic or Gillies flap. So most of the time it is manageable, and if it is not manageable, pedicle flap we do less commonly, and then we move to most of the time to free flaps. So that's my experience also. So are there any other questions? I would be happy to take. So I think if there are no more questions, Dr. Madan, we thank you once again and
Thank you, ma'am.
for a great lecture. And with this, we conclude this session. Thank you.
Thank you.